We'll spend about the next 25 minutes answering as many questions as possible. Dr. Gold and Dr. V just met, so it'd be interesting to hear how they work with each other. But please just be patient. It sounds like they're pretty much on target, that they support the specific carbohydrate diet 100%, and they do offer that as a treatment option in their practice. So thank you so much.
Well, I also thought it was amazing that he and I didn't talk about each other's talks, and yet the two kind of blended and complemented, and it was a nice way to see a mix. And plus the fact he's all grown up since he takes care of adult people too. So you get the full spectrum.
All right, this goes to either one. What is the connection between fluctuations in women's hormones and flares?
I'll let you in on that one.
Okay, I guess I'm
going to defer to my adult
actually,
colleague.
That could also direct you, Dr. Gold, because
okay.
we could also say, what is the connection between the fluctuations in puberty and growth spurts and flares? So we can both address them.
Yeah. So it's a very interesting observation that when people go through hormonal changes in life, that either they flare or they get better, right? If you look at, for example, pregnancy, a third of people get better during pregnancy, a third of people flare, and a third sort of stay the same, sort of historically. And we see that when people go through puberty or menopause, we see things change that way. But even in the same individual, for example, with pregnancy, 3 different pregnancies might go in 3 different directions. So we don't really know. When someone with a menstrual cycle, symptoms can certainly be exacerbated, if you're already flaring. So if you get the disease under better control, it can help. But again, everyone's different. Most people who are going to have issues will get worse during the menstrual cycle, but I've seen it happen the other way around, also. And there are some studies that suggest that taking birth control might actually worsen the IBD, so you have to be a little bit careful about that. Although, if you go into a clinical trial with one of these drugs, they require that all women with childbearing potential be on birth control. So it's not a dramatic thing that happens, but it's more of an isolated thing, with that.
Yeah, I mean, it's the same. I think children who can have a delay of puberty, and I tried to point that out in terms of the growth part. So failure to progress, failure to thrive, where there's no other symptoms. And then we'll often see the ones that are at least not active enough to go progress into puberty, we'll see the changes. But it can go either way, and I think we don't really have a good handle on it in terms of what really the role that the hormones play. There's a lot of data that's looking at IBS and neurogastrointestinal motility disorders and the role that hormones play in terms of symptoms, because there's a number of patients that have Crohn's disease or UC that also have IBS, because you can have both, and that there are clear cyclic changes, at least for women, where they start having periods and their IBS symptoms get worse. But it's the same thing. When we enroll children who are either postmenarchal or have started having periods in clinical trials, they tell us, you got to have them on some form of birth control. And so you got to be careful with that. So I think there's still a lot more research that needs to go into this area.
Can following the specific carbohydrate diet cause a rise in your cholesterol? And if so, why?
I mean, it certainly can cause a rise in the cholesterol. It's one of the things we do monitor over time, but usually there's also a rise in the good cholesterol. And so if you look at the ratio, then, I tend not to get too worried about it. If someone's really running high, we might do some, sit-down dietary modifications, but in general, I don't actually worry about it too much.
Most of the children that we follow they all have a dietitian's always part of the team, and those that we've seen at persistent, we get full lipid profiles, at least at the beginning and at interval points, and most of the ones where you've seen a rise in cholesterol, that persists without a rise in the others. There's usually some other reason that has nothing to do with their IBD, some familial predilection or something that leads to the rise. But for the most part, you'll see if you do see an elevation, it often tends to be transient, but you'll see a rise in other good lipids.
If the diet works by starving off certain bacteria and repopulating other bacteria, would a combination of specific antibiotics and probiotics works as well?
Theoretically, yes, would be the short reason or short answer. I think that there's still a lot that we don't know. For example, SIBO, which Dr. V talked a little bit about, is one of those where normal bacteria that you see in the colon move upstream, if you will, into the small bowel. And there's lots of studies, most of them sort of non-controlled, where they do trials of cycles of antibiotics and trials of probiotics or dietary approaches. There's some very active studies that are going on now in the neonates who have short gut, so the babies that are born prematurely and they end up having some type of resection. Those babies are very much at risk for having bacteria from the colon move upstream. And there's actually some very promising data about both dietary approaches and the use of cycling antibiotics and probiotics. Again, we still don't really know. And more data, there's a lot of data that's looking at that.
Yeah. I mean, I agree. I tend to, when possible, try to avoid antibiotics. I'll try other things first, especially on SCD. Why don't we try some SCDOphilus, and maybe try Saccharomyces boulardii, and then we kind of go from there. Just it depends.
One additional point, Jeffrey, that the National Cooperative Crohn's Disease Study, which was published in the 1970s, it was all adult based. One of the arms was looking at metronidazole or Flagyl. And there were data that showed that it was comparable, at least in mild and moderate disease, to steroids. Nobody was thinking about microbiome. Nobody was thinking about diet back then, or even looking at microbiome. I would venture to say that in those cases, because this drug changes the communities of bacteria, you were probably seeing that type of effect. Again, they didn't have any long-term studies or follow-up with any of these patients, so we don't know what happened to them.
Is there anything we can do to prevent our children from developing inflammatory bowel disease?
Not now, and not maybe next year, but I hope in the future. I mean, I think the thing is that it's hard as a parent to know that there's this thing out there, and particularly if there are people in the family that have the disease. But it's nobody's fault. It happens. And until we do enough research and good epidemiology as well as controlled trials where we understand all the factors that contribute, both host factors, internal from genetics, microbes, and then the exposures that you get from the time that there's pregnancy to delivery and then on, then we're going to be able to determine that. And I think those type of studies are going on now, but we're not yet at that prevention or step yet. I will say that for celiac disease, there's actually elegant work that's going on looking at that specific question, prevention of celiac disease. Alicia Fasano, who used to be at University of Maryland, now is at MGH and moved the Celiac Disease Center there, is doing some really elegant studies looking just at that, at how to prevent gluten-sensitive enteropathy by combination of dietary approaches and microflora manipulation. So stay tuned.
Okay.
So, if you look at, it's not all just genetic, right? Because if you look at monozygotic twins, that means that they're coming from the same embryo. So they got the exact same genetics, usually the same genetic environment. And you have Crohn's disease. Only 50% of the identical twins actually develop Crohn's disease. The other don't. So it's not like a given it's going to happen. Interestingly, in ulcerative colitis, the odds of getting the other twin getting UC is really no different than their other siblings who aren't identical twins. So it's a bit complicated. I see in about maybe 5-10% of individuals you can identify the trigger that kind of kicked off the IBD, but then even if you get rid of it, it's still kind of already happening. So there's not much you can do there. What I tell patients who ask me that question, because we do get it, I tell, look, there's really no great data. But I think this sort of common sense things make sense. I would try to eat non-processed foods, and maybe not go full on SCD, but just eat healthy, eat non-processed foods, avoid things that we know can potentially trigger IBD, things like Advil, Motrin, Aleve, NSAIDs we call them, that can kind of do that. Try to minimize antibiotic exposure, and try to breastfeed your child, if you're at the point where that's still a reasonable option, right? And so that's kind of my common sense approach. That's probably what I would do, but there is no good data on that yet.
Have you seen any patients heal their strictures from SCD alone?
So if you remember when I went through those few slides about phenotyping, that's one of the conditions that now, and again, it depends upon how you define a stricture. A true stricture means you've got scar tissue. So there's no more ability for that section or that piece of the intestinal tract to cause inflammation. SCD is targeted at reducing the inflammation, or helps with reducing the inflammation. So I've seen people who've had strictures where either, and usually it's where they're surgically resected, are on the SCD diet prior to the operation, and then don't get strictures back, at least as long as we've been following them, while they're on the diet. So it's, once the stricture occurs, it's there. It's that sometimes we're not the best at saying what's an inflammatory narrowing, which is not a stricture. So there's reasons for it to be narrowed in terms of the lumen of the bowel, but not necessarily scar tissue. Once there's fibrosis that's there, that stays.
And it can look like a stricture on an x-ray,
Right.
But there's still inflammation there. Most strictures actually have some inflammatory component to it as well. So that if you can get rid of the inflammation part of it, maybe you won't get symptomatic again. Normally a small bowel is about this wide open. It can get down to about that. That's about the size of my pen tip. And someone may still not have symptoms, because a lot of times the strictures happen at the very end of the small bowel where everything's been digested and kind of broken down already. So, and I'm not sure how someone like that can have symptoms, but I've seen it, and I can't quite explain that. And right now we can't get rid of strictures, but sometimes if it's a short one, you can stretch it. There are some surgical procedures where instead of removing the entire piece of intestine, you can actually sort of cut along it this way and then kind of pull it up and bring it around this way, so that you kind of get rid of the narrowing anyways, without actually losing bowel. And even though it's not clinically available right now, there are some studies that suggest that we actually may have some interventions medically that might help reverse at least some component of strictures. I can't talk about that.
Given the importance of strict adherence to the specific carbohydrate diet, how should we handle a fear of cross-contamination during food prep, even when the food preparer is being extra careful?
You can do all you can do. You can't control other people. We were one of the first in the country to start the Camp Kaleidoscope, the Crohn's and UC camp for kids. And now they're sort of nationwide. We have a camp for our celiac patients called Camp We Can Eat It. And we started that now about 7 years ago. And the first summer, we had the camp, and I did the first 3 days of the camp. One of the cooks got sick. Another one of the cooks came who hadn't been trained and used the wrong set of utensils, and I was escorting 2 of our campers to the nearby emergency room after the exposure. So, there's so much. You saw one of the slides that Dr. V put up in terms of potential things that we get from our environment. You can control what you can control. You can worry about it and dream about it at night, but there's a certain point where you try to educate, you try to do the things that you can do, you try to control what you can take in and the people that are preparing the food, but beyond that, I'm not sure what else you can do.
Can you explain how inflammation works and why it can be difficult to reduce even when following the specific carbohydrate diet 100%?
So Dr. Gold put up a real nice schematic, up there. I'm going to kind of simplify it a little bit. Actually, I'm going to show this tomorrow in my presentation, but Sort of imagine that, like, when you have, so all of us have inflammation in our intestines, okay? But it's all a balance. I mean, because we're constantly exposing ourselves to foreign substances, but we also, we don't want to expose to those types of things or have those cause problems, but you want to be able to absorb good things like nutrients and vitamins and stuff like that. So there's like this low level of inflammation in all of us that's there, and it's kept in a fine balance. If things get a little bit too out of control, I think the immune system kind of helps slow that down. And what happens in IBD is that slowing down mechanism doesn't work very well. So it starts to get activated, and you can't turn it off adequately. And so now you have this immune system that's kind of like revved up and overdoing it. So if you imagine little white blood cells, these little white blood cells are programmed, or kind of get reprogrammed. Instead of just fighting off bad things, they kind of get reprogrammed that can actually cause problems and inflammation. So they send out little chemicals to draw on other little white blood cells, and they send out chemicals that kind of cause damage of their own. And so and they clone themselves. So after a while, you got like this clone of like little white blood cells that's just programmed to cause problems, right? So when you do any sort of therapy, the idea is you want to quiet down those overactive little white blood cells to the point that they're not getting stimulated anymore. And if you do it for a long enough period of time, maybe they start to go to sleep. It's kind of like Rip Van Winkle. And then eventually, when you start to reintroduce or either back off your therapy in some form, then when they start to wake up, they kind of forgot what they were programmed to do. So that's my real child descriptive kind of thing. I'm a pediatrician too, but it kind of just conceptually I think works. You need to kind of keep things quiet for a long enough period of time that when the immune system sort of wakes up in that sense in that area again, that it kind of forgets what it's programmed to do. It's
sort of like the whole exciting area now in food allergy, and the whole process of which, is everybody aware of the LEAP study, a study that looked at early peanut exposure rather than late exposure. It originally came, the Ashkenazi Jewish population, which starts with a peanut-containing compound early on in life, were compared to a population that didn't get it, similar genetic background, and the ones that had the early peanuts in life basically didn't develop peanut allergy. And it's really flipped. I mean, the American Academy of Pediatrics got like turned on its ear in terms of, okay, now early exposure. But the whole process of desensitization to food proteins to then be able to tolerate, there's this term in immunology we call tolerance. We need it in society, and it's the same thing. So it's that balance of inflammation, no inflammation, but they're a good level enough so that you're able to tolerate the things that you should and not tolerate the things that you shouldn't.
My immunologist advises against vaccinations due to the fact that it generates major immune system response. My other doctors, including my gastroenterologist and pediatrician, don't agree. What's your thoughts?
See, okay, now he's the adult, and he's going to do it this way. All right, so I'm a believer, and now I'm going to give you a personal story. So my epiphany in terms of leaving, and I didn't leave totally, but leaving the academic world after 17 years at Emory and a full professor of microbiology and pediatrics and going into private practice was really about control of life. But the epiphany happened when I was a quadriplegic in the hospital because I had an adverse reaction to the yellow fever vaccine, which I took because I was going to Iguazu, Brazil. And I'd had the same shot less than 8 months ago. Oops, there was a goof in terms of you're supposed to get it 10 years, not 6 months apart, and it's a live virus vaccine. So I ended up getting this condition called Guillain-Barré syndrome, which, yes, I'm a recoverer from. But when I'm a quadriplegic laying in, I was then at the neuro ICU at Emory, and my mother, who's calling me from California, is saying, "Son, God usually whispers. He's screaming at your butt now. You better pay attention." You sort of have an epiphany. And the long story short is, I think it was the best thing that could have happened to me because it made me really rethink about my life and what I was doing and taking some control back. But I'm still a proponent of vaccines because I think that, and done in the right way, done thoughtfully, and done with the fact that there are ways to administer it so that it's safe, But there are diseases that we're seeing now in people that were completely wiped off the planet, that killed hundreds and thousands of people because there's this belief about that vaccines are all bad and that they're going to do bad things to you. So there is a safe and effective way to give vaccines, and actually the American Academy of Pediatrics, Crohn's Colitis Foundation, our society, and Peds GI, NASPGHAN all have guidelines in terms of how to give vaccines to children with inflammatory bowel disease, eosinophilic esophagitis, which is an allergic disease, and other diseases where the immune system is somewhat suppressed, but still confer protection against those viruses. That's my public service announcement, but I'm a believer in them.
And in really all the years I've been doing IBD, I don't even think I have like a full handful of individuals who had a flare of their IBD from getting immunizations. So I also am a strong believer in immunizing. I have seen individuals get hepatitis B because they didn't get the immunization and then ended up getting a blood transfusion, right? We did a study on vaccines a while back and kind of just, and a third of our patients with IBD had at some point in their IBD cure gotten a blood transfusion at that point already. Because there's a higher risk of, because of anemia, or you might need surgery, things happen. But I've had two individuals who didn't have to get hepatitis B who got it,
What's your advice for getting through pregnancy with inflammatory bowel disease? Should exams be done before conceiving, and are there risks involved?
So, like I said, historically about a third of patients who get pregnant will get worse, a third get better, a third stay about the same. I think the results are actually better than that. But we know that if your disease is quiet going into pregnancy, there's a better chance overall things will stay quiet. You can do SCD and pregnancy. It's a little more challenging, but it can be done. Ideally, you want to. There's a lot of misconceptions. I hate the phone call where I get my patient calling up and saying, Dr. V, I'm pregnant and I'm flaring because I stopped my medications because my genetic counselor told me to do that. So we try to actually be really proactive, and so when I work with a lot of trainees and stuff like that. So when they come in to talk to me about a patient, I'll say, so are they thinking about having a family? And they're like, oh, I didn't ask that question. I go, well, we're going to walk in the room. We should know that because it'll impact where we go with things. And I try to get patients into our pregnancy program where we have one of our IB doctors who specializes in that, and we have a high-risk OB doctor, and they do counseling. And then they reassure the OB doctor that everything's okay if you stay on your medications, or if you stay on your diet, or whatever. And then they're a resource to, to that. So I think trying to be anticipatory and getting the information as good control as you possibly can, and if you can meet with someone who knows IBD, it'll be reassuring for everybody, going through the pregnancy.
And I would add, too, that, just like you're seeing the power of this community, some of the best work has been done by Dr. Kane Sanundra, or she goes by Sandy Kane, who's the chief of adult GI at the Mayo. She also is the current president of the American College of Gastroenterology, and she's got a ton of great information that's available for people thinking about getting pregnant during pregnancy and having IBD. And there's a network that's available to tap into that you can then find out information. And I think I can't echo it enough. The more you can be anticipatory about it, the more you can talk and have get information that's out there and not think that you're sort of alone thinking about going through this, the better it can be.
Diagnosed at age 4, have you seen children with developmental or learning issues, including autism?
That's a great question. I mean, I've seen children with IBD who had developmental disabilities, either neurologic, cognitive, or both. I've seen children with autism who have IBD. So I've seen kids who are severely autistic, who unfortunately we can't and haven't been able to keep on the diet. that are on biologics, and the only way that we can give them their infusion is to admit them to the hospital, where they have to have support because they're big enough and they have enough self-injurious behavior that they've got to be protected. And they're doing well. So I think we have, at Emory at least, and Children's Healthcare of Atlanta, we have a huge network of autistic families. So there's a lot of support systems that are available. But again, there are those resources that are out there. If the question is cause and effect and link, I don't think there's any data really to support the link, but having the two, that has been seen. Lastly, again, I still think, at least that's the advantage, and that's why being at a place like Dr. V is good, because from the adult side and pediatric, it's a team. So we have, two full-time clinical psychologists that are part of our group. We have 4 dietitians. We have a learning specialist that can be tapped into, a child life person. So there's a whole team of people, and we have parents and patients that are sitting at the table before each visit. It's called pre-visit planning, and that are involved in that. So if there are school-related issues, I had a conversation with parents last night about college. There's so many resources now that are available that weren't available when I went to college, that you can have, so you're prepared before you go to college. So the IBD isn't an issue. And if you want to be on the diet, there's a lot of colleges that have the capability of being able to support that at the school. That didn't used to be the case.
I think that they are sort of overlapping potentially, but not necessarily linked specifically in any sort of a way. When someone has more than one condition going on, because a lot of times you see people with, like, ankylosing spondylitis or sacroiliitis or other things like that, we try to find therapies that will address both and not have the rheumatologist, for example, treat one thing, I'm treating a different thing, no one's communicating. We try to look for things that will overlap as much as possible. And the other thing is that, like for the going off to college, like our social worker who meets with all of our patients, I'm very lucky to have an IBD social worker. When kids go off to college, students go off to college, my apologies, then you can get a letter stating, allowing for certain accommodations and stuff like that, be it diet or being near the bathroom or access to this or that. And so it's and if people go to work, right, there's certain work accommodations you can get too, just in case something happens. So she's really good about identifying those things and finding those things. And just in terms of specialists too, again, kind of going back to the pregnancy question a little bit, like when someone asks, like, I want to start an IBD center, what do I need to think about? I'm like, one of the first things you want to do is identify other subspecialists that you can refer to, like a neurologist or an obstetrician or a rheumatologist, an infectious disease doctor, then you can refer patients to. They get much more familiar with IBD specifically and all the issues related to that, and they become by default an expert as well in their area, and it still ties into the IBD. So they're not going to do something that I don't want, and we communicate and stuff like that. I think that's super helpful.
If they can induce Crohn's disease and colitis in rats or mice, how come they can't cure it?
Wow.
You're the microbiologist.
I'll repeat the question.
I heard the question.
If they can induce inflammatory bowel disease in the experimental rats, how come they can't cure it?
So the short question is, you have to understand that these are highly controlled, highly manipulated environments and scenarios in which these are created. So these are genetically engineered mice and rats. So they have specific genes that have been linked to a higher risk for disease that they are then bred to be deficient in. And their microenvironment is manipulated. So they're put in germ-free environments and then where they're exposed. If you can find an individual who is a monogenetic person and has, maybe then in that person it can be cured. But you have to realize that it's a model that's used to control all of the other variables so that you can look at one variable and then an outcome. I think it's a fantastic question, and we were both turfing it to the other. But I do think that if you got back in anything from both of our talks, it was that there are many, many factors that are involved in the onset of IBD. And there are a lot, which is why more research is needed, why large communities are needed that have data that's kept in a repository so the biostatisticians can look at that and start looking at risk. That's how you start seeing what are risk factors and what are not risk factors, and start controlling those so that either A, you can prevent it, or B, you can come up with dietary approaches or therapy or both that can cure it.
So we also look at genetics at our center. And a lot of people do that now, but we have a very huge repository. And there's over 200 different genes that can cause IBD. So if you're looking at a mouse model, if you're looking at a mouse model or a rat model or something like that, you're finding a specific genotype and you're trying to create a specific kind of colitis. But IBD is way more complicated. Some of these genes overlap between ulcerative colitis and Crohn's disease. Some are more unique to each of them. Some overlap with other immune conditions. It's very complex. And what we think of as ulcerative colitis isn't one disease. It's actually a group of diseases. Put that one over here. If we think of Crohn's disease, it's not one disease. It's a group of diseases that all kind of present in a similar fashion. And rather than being sort of two separate circles of diseases, there's actually even an overlap, kind of like that Venn diagram you saw in school, or maybe you're still seeing in school. And it's really more of a spectrum of disease, so it's so complicated that there's really no way that one approach is going to work for everybody. It's just way more complicated than that. And if you look at really almost any study with IBD as a sort of a general overview rule, about 2/3 of people get better and about 1/3 don't, whether there's diet, any specific medication, almost any intervention. So nothing's going to work for everybody, and it's the subtleties that matter.
It's interesting you just said that. I just want to add is that Elaine Gottschall said about 90% of the people who follow SCD with Crohn's disease will be healed, and 75% with ulcerative colitis who follow SCD will be healed. So it's interesting that she could have predicted that so long ago.
Yeah.
Mm-hmm. Let's put our hands together and thank Dr. Gold and Dr. V. It's an honor to have both of you. Thank you so much.
Thank you.
Thank you.